Hello everyone and welcome back. I'm Joe Chappelle and you're listening to episode 28 of the OBGYN podcast. Now, if you're a regular listener, then you might be wondering where I've been for the last few months. Well, I gotta tell you, they were a little bit busy. I got a new job, more on that in a second, and I moved into a new house. So needless to say, I've been a little distracted. My exciting news is that I've accepted a academic position back at Stony Brook Hospital, and I'm very, very happy to be back in academia. I never lost my love of teaching residents and medical students, so it feels really good to be back at it full time. But now that I'm all settled in my new house and new job, I think it's time to get back to work here on the podcast. So today I have a short little episode to finish up PCOS, which I left a little stranded last fall. And after this episode, we'll be back on track, and I have some great stuff coming up in the next few weeks. So with that preamble out of the way, let's get started with episode 24, Polycystic Ovarian Syndrome, Part 2. In our first episode of PCOS, we traced our understanding of the syndrome from our recognition of its symptoms to discovering that the proximate cause most likely lies in the ovary. However, with our incomplete knowledge in regards to that cause, it's hard to come up with a treatment, and so what we're left with is treating the symptoms, and so today that's what we're going to focus on. But before we get into the meat of today's subject, I do want to take a couple of minutes and discuss the main medications that are used in PCOS and how they function, because I think it's kind of important to understand how they're used. Let's start with combined hormonal contraceptives. As you'll remember from the previous episode, ovarian androgen production occurs in the theca cells of ovarian follicles. The arrested follicular development that is the hallmark of PCOS leads to prolonged production of androgens. Now, combined hormonal contraception causes complete follicular arrest, well, at least at normal doses, so hold that thought, which leads to less arrested follicles and decreased androgen production. Now that all makes sense to me and is the straightforward mechanism of action for combined hormonal contraception. The other effects are a little less understood, but OCPs seem to have an effect on the kidneys as well and lead to decreased levels of DHEAS as well as increasing the levels of sex hormone binding globulin, which together also lead to a decrease in circulating androgen levels. Of note is that obese women notice less of an effect, and most likely that is due to peripheral fat conversion of estrogen to androgens. Now, the last note on combined hormonal contraception goes back to those dose levels. In recent years, there has been an explosion of low and low dose pills available on the market. It is important to know what the ovulation rates are with those, because they do vary based on the estrogen dose. For women taking monophasic OCPs with normal doses of about 30 to 35 micrograms of ethinyl estradiol, about 1 to 2% of those women will ovulate per cycle, while women taking a multiphase or the 20 microgram will ovulate about 4% of cycles. As a note, progesterone-only pills, which really are not used in the management of PCOS, will see ovulation roughly about 40% of the time. With this knowledge, we really should be choosing 30 to 35 microgram pills if they're tolerated, because that does give us the maximal follicular suppression and therefore maximal androgen suppression. Additionally, there also seems to be a benefit to shorter pill-free intervals, with 24-day pill packs leading to better suppression as compared to 21-day packs. Now, looking beyond androgen suppression, combined hormonal contraception seems to have almost no effect on insulin sensitivity and a small but probably insignificant change in LDH and triglyceride levels. The next major medication is metformin, which is probably the second most commonly used medication for PCOS. Metformin, as many of you know, is a biguanide that decreases hepatic gluconeogenesis and increases insulin sensitivity by changing really complex intracellular processes. This decrease in insulin levels is associated with a decrease in the insulin-like growth factor 1 to insulin-like growth factor binding protein 1 ratio. Decreased insulin and this decreased ratio results in decreased aromatase levels in the ovary, which overall leads to lower conversion of estrogen to androgens. Also, metformin may directly suppress ovarian gluconeogenesis, which has a direct effect on steroidogenesis, again leading to decreased androgen levels. Lastly, and although this has not yet been proven, these same effects most likely take place in the kidney, which leads to an even further suppression of circulating androgens. The last is spironolactone. Spironolactone is a steroid that is an analog of progesterone. It was first synthesized in 1957, and its anti-androgenic effects were discovered in 1969. In addition to the androgen receptor antagonist activity, it also has anti-mineralocorticoid activity. It works by directly blocking androgens from binding to the receptors, and works very well in combination with other treatments given the different mechanism of action. It also weakly binds to the estrogen receptor, which can cause gynecomastia in men and increase breast size and tenderness in women, especially at higher doses. Well, now that we have a rough idea of how the most common medications work, let's dive into the management of PCOS. And I'm going to start by talking about irregular menses. This is primarily a quality of life issue, but also may impact their risk for developing endometrial cancer. In fact, women with PCOS have about a 2.7-fold increased risk of developing endometrial cancer during their life. And this is most likely due, at least in part, to the oligo-amenorrhea, with women who have less than 4 periods a year being at even increased risks compared to the controls. But at least in the younger reproductive years, the quality of life is really the main concern, because these women can have unpredictable and heavy menses. Now thankfully, both these issues can be dealt with by using standard hormonal contraceptives. OCPs, the progesterone IUD, or even IM progesterone are all quite effective in regulating menses, and as a byproduct also decreasing endometrial cancer risk. Now, I do want to be clear that there actually are no studies that prove that any of these methods have an effect on endometrial cancer incidence, but it makes logical sense that they would, and most people believe they do. Another method for women who either do not want combined hormonal contraception or an IUD, or maybe aren't candidates for them, is to use intermittent progesterone to force withdrawal bleeds. Now, this can be done as often as preferred by the women, but given the previous study, with having less than 4 periods a year being at increased risks, I recommend to my patients that they do it at least every 3 months, but it can be done more often or even monthly if the woman prefers. The next symptom that we regularly encounter in these women is hirsutism, which for many women is the most outwardly facing manifestation of the syndrome. It manifests as increased male pattern facial and body hair growth and is caused by high levels of circulating androgens. When treating these women, it can be helpful to use a hirsutism score to better monitor for success. One of the most common is the Modified Ferriman-Galloway score. This method scores 9 body areas: the upper lip, chin, chest, upper and lower back, upper and lower abdomen, arm, and thigh. You'll note that 2 main body parts are missing from that score, and that's the forearm and the lower leg. And they're excluded because they're very, very sensitive to even low levels of androgen, and women with normal androgen levels can still have a lot of hair there. Each body area is given a score from 1 to 4. 1 represents minimal visible terminal hair growth. 2 if it's more than minimal, but less than a normal adult male. 3 if it's equivalent to a, quote, not very hairy male. And 4 is equal to a well-virilized male. This score was made with people of European descent in mind, and I want to note it may be quite different when applying this to either African or Asian women. But in any case, according to the score, a score greater than or equal to 8 is considered hirsutism, and that's considered mild up to a score of 15, from 16 to 25 is moderate, and over 25 is severe. Now, it is important to ask women if they shave, wax, or use laser or electrolysis before you score them, because that can throw it off. Now, the score is a great tool, but as you can see, it is very subjective, and it really only concerns the hair growth associated with hirsutism. Some women really manifest as having increased acne or even alopecia, and they don't have the typical hair growth that we think of with PCOS. So we just need to be aware that this is not the be-all end-all of diagnosing hirsutism. But how do we treat it? Well, excess androgens are really the problem here. So if we want to eliminate the symptoms, we need to suppress the circulating androgens. And as we discussed, OCPs, metformin, or peripheral androgen blockage is really the way to go. Now, there are no randomized controlled trials on the use of OCPs for hirsutism, but there are observational studies which reported a 61 to 100% reduction in those hirsutism scores. So this is really a good first-line therapy. Metformin, as we already discussed as well, also decreases androgens and seems to have a similar clinical effect to OCPs. And there are some randomized controlled trials comparing metformin to OCP, and they're kind of mixed results and they're probably equivalent. I will note, though, that the mechanism of action for metformin means it does take longer for the treatment to have an effect. And lastly, for metformin, the effects are probably additive with OCPs, and although there are no studies that really show the combined therapy, a lot of people use them together for severe hirsutism. Now, when neither OCPs or metformin are sufficient, there is another class of medications, and we talked about those already, and those are the anti-androgens. And those can either work by blocking the androgen receptor, like spironolactone, or inhibiting 5-alpha reductase, like finasteride. In head-to-head studies between these two, there really doesn't seem to be any difference in their efficacy, and using them in conjunction with OCPs seems to even amplify their effects. There is one of these that I do want to mention that is flutamide, which can cause severe liver toxicity, and so it's really not used at all. But other than that, these are relatively safe. The one thing you do have to worry about when you have women on either spironolactone or finasteride is, as you can imagine, they are extremely teratogenic to male fetuses, and so they should always be paired with a contraceptive of some sort anyway to prevent pregnancy. In addition to oral medical approaches, you can also use topical treatments like eflornithine, electrolysis, or chemical or laser hair removal. Eflornithine is interesting. It's an irreversible inhibitor of L-ornithine decarboxylase, which catalyzes a conversion of ornithine to putrescine, which is a key part of hair growth. It's actually very effective and can reduce hair growth in the face up to 70%. Now, I say face because it's actually not approved for any other areas of the body, because there is a concern for thrombocytopenia and even seizures with large systemic absorption, so they don't want you using it all over your body. As a side note, and kind of interesting, this medication was actually first developed, or first used, I should say, for treating African sleeping sickness. So there is that. Now, before I move on to the next topic, I wanted to take a minute and talk about OCPs that have drospirenone as a progesterone component. In the U.S., this was first marketed as Yaz and developed a large following due to the anti-androgenic effects of drospirenone. Now, drospirenone is an analog of spironolactone, with the replacement of the acetyl group with two methylene groups. The substitution dramatically increases its agonist effect on the progesterone receptor and also increases its antagonistic effects on the androgen receptor. These effects make it an ideal candidate for women with PCOS because it both suppresses circulating androgens by its progesterone effect and decreases the receptor availability for those androgens. It was released in the U.S. in 2000 and became quite popular. As you can imagine, even in women without PCOS, the anti-androgenic effects work quite well for acne. In the late 2000s, however, we started to learn that drospirenone has an even greater risk of venous thromboembolism than other OCPs. And I want to give a few numbers here. So women taking OCPs with levonorgestrel as a progesterone have an incidence of about 9 VTEs per 10,000 women years, while for drospirenone it's 27 per 10,000 women years. Now this is of course a 300% increase, but the actual numbers are small. In my practice, I still do use drospirenone, but I try to reserve it for women with either severe acne or with PCOS with hirsutism, because if I don't need to put them on something that does have that higher risk of VTEs, then I won't use it. But I do find that you still want to keep it in your toolbox. Now, next up, the thing I want to talk about is subfertility. Given the follicular arrest that we discussed in the last episode, these women do not ovulate regularly and therefore have difficulty getting pregnant. In addition, there's a subgroup of women with an additional likelihood of increased miscarriages even if they do get pregnant. And these women tend to have greater degrees of hyperandrogenism and hyperinsulinemia, which is thought to impair oocyte development and specifically impairs meiosis and fertilization. And it seems that women from South Asia have the highest rate of this PCOS variant and even have diminished rates of IVF success. Regardless, as I just alluded to, the treatment of this subfertility often requires reproductive assistance. Because this subfertility is in part caused by hyperinsulinemia, giving metformin to decrease insulin resistance and circulating insulin levels can reverse the process somewhat and allow some women to ovulate spontaneously. Now, even when this does work, it does take time, and so it may not be the optimal approach for women on the older end of the reproductive window. However, even if other methods are going to be employed, many people still use metformin as an adjuvant therapy. Now, in women who fail to ovulate with metformin, or really just need a more rapid approach to pregnancy, ovulation induction is the way to go. The most common method is to induce ovulation with clomiphene citrate, or Clomid. Clomid works by binding estrogen receptors, and it blocks the negative feedback loop to the hypothalamic pituitary unit. This in turn leads to increased GnRH secretion, which then leads to an increased LH and FSH secretion. So in many women, this leads to ovulation, But if not at the first dose, you can always increase the dose, and many people will give up to 3 cycles before alternative methods are employed. One of those alternative methods is letrozole, which is an aromatase inhibitor that was initially developed to treat breast cancer. It works by blocking the conversion of androgens to estrogen. Now, this kind of seems counterintuitive in PCOS because that is one of the intra-ovarian problems that these women face already. But it seems that this complete blockage and subsequent precipitous drop in estrogen removes any inhibition of FSH. These levels then spike and are able to overcome the arrested development of the oocytes. Letrozole is not currently approved for this use in any country, but it is used off-label in the US for women who do not respond to clomiphene. Now, if neither of these approaches work, then there are some more drastic things we can try, like giving GnRH directly, doing ovarian drilling, or even IVF. But we have to keep in mind that these do have an increased risk of complication and, of course, are much more expensive. Now, that pretty much covers the major symptoms that women with PCOS experience. So what I want to do now is finish up by moving on to the long-term risks that these women face. Since we are talking about pregnancy, why don't we start there? Because once these women do get pregnant, they are still at high risk for bad obstetric outcomes. The most common pregnancy risks are for preeclampsia and gestational diabetes. This makes sense due to their low parity, high BMI, and higher rate of multiples. However, even in women with only a few or none of these issues, they are still at risk, which is probably due to the hyperinsulinemia and inflammation that goes along with it. Interestingly, this theory was recently corroborated by a study that demonstrated that metformin in pregnancy reduces the incidence of preeclampsia similar to baby aspirin. So these women with PCOS need early screening for GDM and need to be monitored for hypertensive disorders of pregnancy, and based on that recent paper, maybe metformin and baby aspirin together should be employed. Now, moving away from pregnancy but staying with diabetes, I think no one here is going to be very surprised when I tell you that these women are at higher risk for developing type 2 diabetes than their non-PCOS peers. This is because the insulin resistance in PCOS is, as one peer put it, independent and additive to that of obesity. About 60 to 80% of women with PCOS will have insulin resistance, and if they're obese, this number spikes to 90%. The scary thing here is that this can start as early as adolescence, and of course that means it has a lifelong impact. When comparing women with PCOS against age and weight matched women without PCOS, the women with PCOS have a 5-fold increase of having impaired glucose tolerance or overt diabetes. Now, I don't want to take the time to detour into the downstream effects of diabetes, but we all know that the longer and more severe that glucose intolerance is, the worse the outcomes. And one study calculated that 40% of all the economic costs for PCOS comes from treating diabetes. So this makes it very important that we think about this when we're doing our initial screening of these women and their workup and management. Additionally, starting insulin-sensitizing agents like metformin at the first signs of glucose intolerance can help decrease progression and the morbidity associated with it. The next topic I want to talk about is cardiovascular disease. This follows a similar pattern to diabetes, where women with PCOS are at higher risk, and even higher risk if they're obese. These women are at risk for hypertriglyceridemia, high LDL levels, low HDL levels, and upwards of 70% of women with PCOS will have one or more of these. These effects are thought to be due to the high levels of androgens, which, like diabetes, obesity makes worse. And about a third of women with PCOS will have metabolic syndrome, which then even leads to worse issues. Given all this, it is no surprise that women with PCOS have higher rates of cardiac and cerebral accidents, as opposed to matched controls, and that even worse, they have lower survival rates and higher recurrence rates. To me, again, like diabetes, this emphasizes the need for early and regular screening in women with PCOS, even perhaps starting in adolescence. The treatment of dyslipidemia is similar to women without PCOS. It starts with lifestyle modifications, and even though this doesn't really seem to have great long-term results, we know that women who exercise, even if they have the same BMI as someone else, they do better. But as diet and exercise are rarely enough for these women, we need to treat the underlying metabolic issues. Now, like I said before, we should focus on insulin resistance, but unfortunately, this is one of the few areas of PCOS where treating that doesn't seem to have that much effect, although it probably can't hurt. Other than that, the treatment is very similar to women without PCOS. We got to control their cholesterol, control their blood pressure using the current guidelines. I think the important takeaway for me here is I need to consider all of these factors when treating someone with PCOS and not just assume that the general care doctor or primary care doctor is taking care of these. Now, the last topic I want to talk about, and I think it is very, very under-discussed when it comes to PCOS, is the psychiatric effects. About 25 to 40% of women with PCOS will experience depression, 10% will have anxiety, and over 20% will binge eat. Now, part of this is undoubtedly due to societal pressure related to obesity and hirsutism, but there's also evidence that high androgen levels themselves can affect mood, with one paper finding a linear relationship between depression scores and free testosterone levels. Now, there's not a lot of research here on this topic, and treatment seems to be standard. It's just the prevalence again that I want to bring up. Almost 50% of women with PCOS will have anxiety and or depression. That's just a huge number, and we need to make sure that we are screening appropriately when we encounter these women or when we see them on an annual basis. Now, that pretty much wraps up my discussion about PCOS, and we could spend hours diving into any of these subtopics, and I'll include references for people who want to chase that rabbit. But before I go, I wanted to talk a little bit about why PCOS even exists, because patients sometimes ask this. Now, like many traits found in nature, we think there must be or must have been some evolutionary advantage or it would not have persisted. And because PCOS is prevalent in all populations, it most likely arose very early in human evolution. And although women with PCOS are definitely less fertile than their peers, they are rarely infertile, especially when considering their early reproductive age in ancient times. Women with PCOS have less children on average than women without, and this itself might have been advantageous, especially in times of nutritional scarcity. Additionally, these women were likely to have higher muscle mass and bone density due to those elevated levels of insulin and androgens, which certainly could have been to their advantage. Along those same lines, the propensity to store fat, which is considered bad in modern times, might have been a good thing when the cyclical nature of food scarcity meant that having a little extra fat might keep you alive a little longer. Lastly, and related to this theory, is that this extra fat might allow you to continue to ovulate when food supplies were low, when other quote-unquote normal women would not due to starvation. The truth probably lies somewhere in there, and I do find this stuff fascinating. The human body is so complex, and every advantage has its consequences. And realizing that PCOS is not a disease, but perhaps an adaptive measure that is no longer needed, may also help women with this syndrome understand that there's nothing wrong with them. Maybe that knowledge won't help everyone, but in my personal experience, there are women who find comfort in that fact. And with that, I think I'm ready to drop the curtain on PCOS. I hope you all enjoyed this very late episode of the podcast, and I look forward to bringing you more soon. As always, you can leave feedback at obgyn.fm. And until next time, thanks for listening.